Hello, everyone, and welcome to another enlightening episode of MedSynapse podcast series. I'm Hetvi Shah, your host, and today we are diving deep into the intricacies of Lewy Body Dementia, a condition that is often misunderstood and misdiagnosed. We will explore its unique challenges, management strategies, and latest advancement in the treatments. And to address this issue, we have an extraordinary guest with us. Dr. Sinjan Ghosh, a renowned neurologist with over a decade of experience in neurology. He's here to unravel the mysteries of Lewy body dementias. Dr. Ghosh has an impressive background, having trained in Kolkata and completed a clinical fellowship in cognitive and behavioral neurology at University of Toronto in Canada. He's an active member of several prestigious neurological societies and is deeply involved in cutting-edge research and public awareness initiatives. So, welcome Dr. Ghosh, and we are so thrilled to have you with us today.
Thank you so much, ma'am. And it's a pleasure and honor to be here today. And thank you very much to MedSynapse for arranging these kind of sessions. Thank you so much.
Thank you so much, Doctor. So let's kick things off with the basics. So could you explain what exactly is Lewy body dementia and how does it differ from Alzheimer's disease, because the symptoms and everything are usually the same?
Right. So we find that people discuss a lot about Alzheimer's disease, but there are different other subtypes of dementia that we usually get in our clinics. But we don't discuss those disorders often. So in terms of Lewy body dementia, it is the second most common type of neurodegenerative dementia after Alzheimer's disease. Alzheimer's disease being the most common one. So what happens in Lewy body dementia? Basically, Lewy bodies are abnormal proteinaceous deposits which get deposited on different parts of our brain, and they manifest in different ways. So they can present with Parkinsonism, they can present with problems in cognition, right? So in Alzheimer's disease, we usually see that it starts with cognitive problems, predominantly memory, while in cases of Lewy body dementia, we find that people have problems with attention, problem with executive function, or like whatever they do in their day-to-day life, things get clumsy, and the features are subtle, but eventually the families would get to know that they are having these kind of problems. So when these cognitive problems start affecting the activities of daily living or day-to-day life gets hampered, so then we call it as dementia. And whenever we suspect this pathology might be due to Lewy body deposition, we call it as Lewy body dementia. Now, Parkinson's disease also have these Lewy bodies, but they have predominantly motor symptoms, right? There's slowness of activities, tremor, and the tremor in Parkinson's disease is usually asymmetric. That is, one side is more than the other side. While in Lewy body dementia, the Parkinson's disease can be symmetric. Now, Alzheimer's disease progresses, and eventually later they might have some slowness of activities, but things start off with cognitive problems. But in Lewy body dementia, it can start either with Parkinsonism or with dementia or cognitive problems, but usually they occur either simultaneously or within a span of 1 year. So that is a major difference.
Yeah, thank you for highlighting the difference. So also it is very crucial for better patient care, as in when you diagnose the disease correctly.
Absolutely.
So now, given the overlap in symptoms between LBD and other neurodegenerative disorders, what are the key diagnostic challenges you face in clinical practice and how do you overcome them?
All right, that's a very pertinent question. So basically, Lewy body dementia has features of both Parkinsonism as well as dementia. And sometimes it is confusing that whether the patient has Alzheimer's disease or they have vascular dementia. Whenever somebody has multiple small strokes or maybe a large stroke and then other smaller strokes, we call it as vascular dementia when it affects the cognition. So that is another differential. So in terms of neurodegenerative disorders, Parkinson's disease and Alzheimer's disease are the top differentials for Lewy body dementia. So as I mentioned, if we have to differentiate with Parkinsonism, so whenever we see patients in the clinic, we ask them how things started. So either it started with tremors, or it started with slowness of activities of daily living, or they had a fall, they're having a gait imbalance. So eventually what happens is that they would have those motor features of Parkinsonism, and after several years they would develop some cognitive problems, and eventually they might develop dementia. So if it is the cognitive problems start at least a year after the onset of motor symptoms of Parkinsonism, we consider it as most likely Parkinson's disease with dementia. But if the Parkinsonian features are closely followed by cognitive problems, or the cognitive problems precede the Parkinsonian features or motor features like tremor and slowness, then we think of Lewy body dementia. But sometimes the history is not clear. So that's when we take the help of various investigations, right? So we do have some cognitive test batteries as well that we do in our clinics, pencil and paper tests, from which we identify the cognitive domains which are affected. For example, if it is predominantly memory that is affected, then we think of probably Alzheimer's disease. If it's predominantly motor symptoms and cognition is not that much affected in the earlier stages, then it is most likely Parkinson's disease. And if attention, executive function, as well as visuospatial functions are affected, then we consider it as probably early stages of dementia with Lewy bodies.
Okay, that is insightful. And one, I just had a question from this, are there any chances of misdiagnosis after this?
Absolutely. So in the best centers throughout the world, it's said that around 20 to 30% patients might be misdiagnosed. Not that their management would differ a lot, but what happens is that to come to a diagnosis, some people might look like Alzheimer's disease, but they might have Lewy body pathology in their brain. So many studies looking at brains, the autopsy studies, what they have done, they have found that somebody who was diagnosed in one of the best centers in the world with Alzheimer's disease, they did have Lewy body pathology. So this is intriguing, and it's really fascinating how there's a difference in the clinical features and the pathology, right? They can manifest in different ways, but the rule of thumb is what I discussed, right? Whenever we have a problem with the diagnosis, the most important part is to go back in time and look at the history and ask a very well-informed and close informant who knows what had happened and how it evolved over the years. So that makes a lot of difference. And then we come to different biomarkers, different tests. Like we do imaging, CT scan or MRI scan of the brain. So it depends upon the area of atrophy of the brain. So in Alzheimer's disease, mainly the medial part of the temporal lobe is atrophy. Whereas in Lewy body dementia, the medial part is not that atrophy, but the posterior part or the occipital part is more atrophy, right? So if we look at the test scores, the cognitive test batteries that we do, if we look at the test scores and we look at the MRI and find that it's not matching well, the magnitude of cognitive problems that they are having in their tests that's not reflecting in the MRI. The medial temporal lobes are not that much active. Then we think of probably we are dealing with Lewy body dementia. And then we confirm it by doing a FDG PET scan. So that is very helpful in differentiating between the two. So what happens is that in FDG PET scan, there's a specific sign called cingulate island sparing sign. The posterior cingulate area of the brain is spared in dementia with Lewy bodies, but affected in Alzheimer's disease. So that is one of the very important differentiating factors. And then also there's DAT scan, which can look at the uptake in the basal ganglia, and then they can help in differentiating between Alzheimer's disease and dementia with Lewy bodies.
Thank you for highlighting that. I think proper diagnosis is key to effective management.
Absolutely. And also we have CSF biomarkers as well, cerebrospinal fluid. We do fluid biomarkers. There are tests for Alzheimer's, which helps in determining whether the patient has Alzheimer's pathology or not.
Okay, thank you for highlighting that. Now, managing neuropsychiatric symptoms like hallucinations and REM sleep behavior disorders in LBD patients can be complex. So how do you handle these without exacerbating other symptoms or causing any significant side effects?
Yeah, that's a very important practical perspective into the disease. Even after we diagnose it, treating Lewy body dementia is really challenging. First of all, the diagnosis can be delayed because if sometimes dementia with Lewy bodies patients do have visual hallucinations. So sometimes it can so happen that physicians might diagnose them as a primary psychiatric condition rather than a neurodegenerative disorder. So before we get a diagnosis, it can be a delay of say around 2 or 3 years. So that's the major challenge. So when we get the patient, it's already in the advanced stages. So when we start treating them, the important part of dementia with Lewy bodies treatment is that they have adverse reaction to antipsychotics, which are used in agitation, aggression, and behavioral issues of dementia. So they can have a condition called neuroleptic malignant syndrome, right? So it can be life-threatening as well. They can become stiff. They can have high temperatures and host of other problems. They can be almost knocked out and may go into coma as well. So that's why it is very important to identify what subtype of dementia we are dealing with. Then we can be cautious about using the medications, right? So we usually, if we have to use antipsychotics, then for hallucinations and delusions, we can use quetiapine or clozapine, right? They're safer as compared to other antipsychotics. And apart from that, in Lewy body disease, we find that there are various studies as well which have shown that cholinesterase inhibitors such as donepezil or rivastigmine can work wonders as well in some patients without having those adverse side effects as I mentioned with the antipsychotic medications, right? They can help in improvement of the cognition as well as the hallucinations, right? So the most important like the features that you mentioned, hallucinations and REM sleep behavior disorder, these are two vital features of Lewy body dementia. So what happens is in REM behavior disorder is that people can talk, they can scream while they are sleeping, and they can actually punch and kick their spouse or bed partners. So they can hurt themselves as well. So that's why we need to take care of the sleep hygiene of the patient as well as the surroundings. There shouldn't be any sharp objects, anything that might hurt them. And those are the non-pharmacological approaches. For REM sleep behavior disorder, we have two medications such as melatonin and clonazepam, which can work in reducing these kind of symptoms, these aggressive behaviors. It's almost like enacting the dreams, right? So we have to address those with these medications and also the other non-pharm approaches as well.
Yes, these can be quite challenging sometimes.
Yeah, absolutely.
So now, how do you approach the overall management of Lewy body dementia given its unique challenges that you mentioned?
Yeah, absolutely. So sometimes it so happens that we do see patients with delirium, right? Somebody has urinary tract infection, chest infection, sodium potassium imbalance, dyselectrolytemia. So they can present with delirium. If somebody is having frequent episodes of delirium and requiring hospital admission, we should start thinking of probably they might have an underlying neurodegenerative condition. So we need to be careful while using the antipsychotic medications, because we know that since we don't still have the diagnosis, they can end up with a life-threatening condition. So that's why we should be cautious about using antipsychotics, and we should be keen on actually working up as to what the underlying diagnosis might be. If it's a possible Lewy body dementia, then we have these non-pharmacological approaches as well as various medications that would help them in managing. And also, there's another medication called pimavanserin, which is used in Parkinson's disease psychosis, which has been approved by the US FDA. So it has been tried in Lewy body dementia as well. So what it does is that it doesn't cause drug-induced Parkinsonism, or it doesn't worsen the motor aspects, but it helps in controlling the psychotic behaviors like hallucinations and delusions. So these are other options as well. And the diagnostic part, as I mentioned, sequentially MRI and a PET scan helps in identifying as to what is going on, and also the fluid biomarkers, as I mentioned. So training the family members and caregivers is also an important aspect, because many a times it is more challenging than Alzheimer's disease, this Lewy body dementia. It takes a toll on the mental and physical health of the family members or the caregivers. So that's why we say it's not like treating a patient, it's like treating a family living with dementia. So somebody who has a family member or a relative who has dementia would understand what I'm talking about. So it's very difficult, because we know that it's not curable. We have to treat and manage the symptoms. We have to take care of our response as well, because sometimes it might seem that why does it have to be like that? But we have to understand that their brain is getting atrophied. There are imbalance in their chemicals in their brain, the neurotransmitters. So things are happening. So we have to manage with compassion. So that's
Yes, rightly said.
very important.
Rightly said, a comprehensive approach is very essential.
Yeah, and it's a multidisciplinary team approach. Physicians, including psychiatrists and neurologists, physiotherapists, occupational therapists. We have speech language pathologists, because they can have swallowing problems as well. And we have to monitor their blood pressure regularly. A trained nurse who can monitor the blood pressure, because they can have autonomic dysfunction as well, fluctuation in their blood pressure or heart rate. So there can be cardiac issues as well. So we have to address those things, and those who are adept in managing these kind of patients, they can actually formulate an individualized care plan. We have a care plan for each and every patient, and that is different. You won't find it in textbooks. Through experience and discussion, we actually come to a solid plan. And it also depends upon the individual, like what kind of a person they were before they developed dementia. What are the things that they loved? What are the items they love to eat? So everything should be taken into consideration, and then we set out a
That
management.
can be quite complex. Now, looking to the future, what do you think are the most critical areas of research that need to be addressed to improve the diagnosis, treatment, and the overall understanding of Lewy body dementia?
Right. So, so I always tell my patients that Alzheimer's disease is a popular condition, but the other subtypes of dementia are not. So they need to be actually educated about what are the symptoms, like early features of visual hallucinations and some cognitive problems and slowness of activities. Whenever they find a cluster of these kind of symptoms, they should think of consulting a neurologist right away, because if it is diagnosed in early stages, we can actually make a difference in their quality of life, and they can actually stay at a good level of functioning for quite a bit of time. So that's important. And also training the other physicians. So it might not happen that they would end up with a neurologist or a psychiatrist or a psychologist. So other physicians should be able to pick up the subtle features, right? So if they see that they are having visual hallucinations, or they are having fluctuations, they are telling you that I'm having some good days and some bad days. Sometimes family members would say that, doctor, sometimes I feel they don't have anything, like they're absolutely normal. But on some days I feel like they have advanced dementia. So what's happening? So it's still unclear as to why this happens, but this is an important feature of dementia with Lewy bodies, that they have fluctuation. Even if they are not on any medications, but they didn't miss any pills, but still they can have these fluctuations. So it gets challenging when we see them in their good days. So we won't get the extent of their disease, and we won't understand the plight of the family members. And when we see the patient during their bad days, we might give them medications at doses that they might not need, right? They might need lower doses. So that's why the informant has to be responsible and has to actually monitor the patient as what is happening, and always to be discussed with the physician who is treating the patient. So I think educating the family members as well as the physicians from other subspecialties or specialties is extremely essential. And then coming to the diagnostic approaches, so we shouldn't delay the diagnosis. Okay, so let's see how things go, and then we'll do one MRI of the brain. It doesn't make any sense, because we are not helping them, and it is not going to get better without any treatment, right? So that's why that is important, that we need to address it as early as possible. And there are a lot of people, and there are different centers who are still carrying out research on Lewy body dementia. So we hope for a brighter and better future. So
Yes,
we have the Alzheimer's disease anti-amyloid therapies, which have already been approved in the US FDA. So it might come to India soon. So we are still hoping for the other subtypes of dementia, if we
yes.
have a cure someday.
Let's hope for the best.
Absolutely.
And thank you for that piece of advice for all the healthcare professionals watching this.
Thank you so much. And I'll be happy to take questions.
Yes, definitely. We would have some on the comments below. So before we wrap up, I was just looking into your bio and I was intrigued to ask one question, if you would allow. Could
Sure.
you tell us a bit about your current research and any exciting projects that you are recently interested in?
I was working, while in Toronto, I was working with premorbid psychiatric conditions and their effect on advanced dementia and these behavioral features, because what happens is the psychiatric conditions and these neurodegenerative conditions go hand in hand. Sometimes what happens is that these psychiatric disorders can be a prodrome of an imminent neurodegenerative condition in evolution. they can be a risk factor for the neurodegenerative condition, and they can be a consequence of a neurodegenerative condition, right? People with dementia do have depression, anxiety, anger outburst, agitation, physical aggression. So this gets really difficult. So we try to look into the families with dementia, and we also looked into the psychiatric disorders that they had in the family, including suicidal tendencies. And it was remarkable that we found a statistically significant association between psychiatric conditions and advanced neuropsychiatric symptoms in dementia. So when I reviewed the literature, I found that there's a significant overlap between dementia and psychiatric condition. So it might so happen that it is basically a continuum. So there was already a predisposing factor, maybe a gene, and there were changes in the brain network, the microcircuits, which might not be picked up at a very early age. So, say somebody in their 20s or 30s, they have some psychiatric condition, but the MRI brain doesn't reflect any atrophy, right? It eventually sets in. So what it boils down to is that if we see families having psychiatric problems, we can actually work with them, and we can try to find out biomarkers as to identify who are predisposed to develop a neurodegenerative dementia later in their life. So that would be really helpful. And I'm also interested in artificial intelligence and how it would aid in the diagnosis. And as everybody would ask, whether AI is going to replace physicians, I don't think so. It wouldn't ever, because those subtle features that we pick up during our examination, right? We ask them phrases and ask them to pick up sarcasm. Those subtle things AI can't pick up, right? So there has to be a physician who is trained in AI, then we can take this subfield forward.
Yes, rightly said. It would make life better for physicians.
Absolutely. And patients and families.
Yes, of course.
Yeah.
So, as we wrap today's session, I would like to thank Dr. Ghosh for sharing your expertise and these compelling insights with us today. Your
Thank you
knowledge
so
has
much.
your knowledge has actually provided us with deeper understanding of Lewy Body Dementia.
Thank you so much. It was a pleasure talking to you, ma'am. Thank you.
Same here, same here. And thank you to our listeners for tuning into this episode of MedSynapse podcast series. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, don't hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay healthy.